Welcome everybody to this BRISE webinar. I'm on the lands of the Bidjigal people of the Eora Nation, and I pay respects to elders past and present. And as we're talking about hepatitis C, or viral hepatitis today, we note, of course, the overburden of viral hepatitis that Aboriginal people have lived with and survived for many decades. Sorry, my just caught my throat there. So BRISE is a New South Wales Ministry of Health investment in research and evaluation in the BBV STI field. And the Centre for Social Research in Health, where I am, has the pleasure of sharing this investment with the Kirby Institute to conduct research and evaluation around the strategic priorities of the ministry. And one of those today that we'll hear about is insights on viral hepatitis elimination. So we've got 3 speakers for you today. Some of you may have received an invitation with only 2, but we aim to please. So we have an extra added bonus person with us today. So we're going to kick off in just a moment with Scientia Professor Greg Dorr from the Kirby Institute, who'll lead us through the latest in-data linkage results. And then following that, Dr. Natalie Smood from the Multicultural HIV and Hepatitis Service will provide some response. And then our third speaker will be Tracy Brown from the Justice Health and Mental, sorry, I've completely lost that name. Tracy, can you help me out?
Justice Health and Forensic Mental Health Network.
Couldn't get the F, sorry. So we're going to go through these 3 presentations, and then we'll have some time for discussion and questions and answers at the end of that. Also, to let you know that we're recording this session, so we routinely post the recordings to everybody who registered for this, so that people who may not have been able to attend today can follow up with the recording later on. So hello to that group of people as well. So without any further ado, I'll pass over to you, Greg.
Thanks very much, Carla. I'll just share my screen. Is that showing now? I got to.
Oh, can you swap?
Yep, swapped it. How's that?
Perfect.
Thanks very much, Carla. And like Carla, I'm also on the lands of the Bidjigal people, and I'd like to acknowledge elders past and present and pay my respects to those from First Nations communities who are on the webinar today. I'd also like to acknowledge the work for this presentation contributed by Heather Valerio, postdoc in our program, and Shane Tilakaratna, a PhD student in our program. And much of the analyses and slides Shane and Heather have put together. Really appreciate their support. So I'll try and give you an overview of where we're up to in terms of our data linkage project that's been funded by BRISE, and really like to acknowledge New South Wales Health for their ongoing support of the project. There's a fair bit of data I'll be presenting. Hopefully I'll be able to present it in a reasonably accessible manner. Just to refresh people in terms of the WHO elimination targets, there have been some revisions to the target, and in the context of what I'll be presenting today, a couple of key revised targets to focus on. So these are targets for liver-related deaths at what we call the population level. So for hepatitis B, the target is less than 4 per 100,000 population per year. And for hepatitis C, somewhat lower because globally the burden is greater for hepatitis B. So for hepatitis C, it's less than 2 per 100,000 population per year. So a combined sort of target of liver-related mortality of less than 6 per 100,000 per year. So just keep those numbers in mind when we come to some of the liver-related mortality estimates. And the reason for this revised target is that previously they did have a relative reduction of 65%. And for reasons that I'll explain, it's much more feasible to look at the sort of crude population level targets rather than trying to estimate the change from 2015 to 2022. And it's less dependent, obviously, on the age distribution. That's important. Okay, just in terms of our linkage, we have an ongoing linkage project that links all hepatitis B and C notifications in New South Wales over the almost 30-year period from the early 90s through to the present time. And we've just about cracked 200,000 notifications. So 199,000 notifications of either hepatitis B and hepatitis C. And obviously there's some that have been notified for both. And we link to several administrative data sets. Key for these data presentation is hospital admissions and death registrations. We have some linkages that are still coming through from AHW that include, importantly, some new linkages that we've added in. So we have linkage of homelessness services and also linkage through Domino of social support services. So it'll be really interesting to get a sort of more granular sort of demographic picture of how we're sort of tracking in terms of elimination. We also are awaiting the MBS linkage and importantly the PBS linkage in terms of Hep B and Hep C treatment. This is a previous paper that we published just to give you a bit of background. So we've been monitoring trends in decompensated cirrhosis or liver failure, hepatocellular carcinoma or liver cancer and liver-related deaths among people with hepatitis B and hepatitis C. So this is data on hepatitis C. And we classify people that are admitted to hospital with their first presentation with liver failure or liver cancer, and then who die subsequent to those presentations as liver-related deaths. So you can see prior to the advent of the elimination era, there's this increasing burden of liver failure, liver cancer, and liver-related deaths. So we'll extend these analyses through to 2022 in the data that I'll show you today. We also use the linked data, what we call the empiric data for New South Wales to help calibrate and validate our models of how we're sort of progressing in terms of the hepatitis C epidemic in New South Wales and Australia. So you can see here our empiric data for New South Wales linkage in the blue and our model data in the red, very closely aligning with liver cancer and liver-related deaths. There's some reasons why the empiric data through linkage is giving a higher estimated number of liver failure events, but still the trends are very, very similar. So let's look at the latest data, both for hepatitis B in the blue and hepatitis C in the red. Firstly, for decompensated cirrhosis, so these are actual numbers of new diagnoses through that admission criteria to hospital over time. And you can see with liver failure, there's quite marked reduction in the number of people being diagnosed with decompensated cirrhosis. Hepatitis B had always been somewhat lower in terms of decompensated cirrhosis admissions and diagnoses. In terms of liver cancer, you can see a less marked turnaround in terms of hepatitis C compared to with decompensated cirrhosis, but nonetheless, there was a steadily increasing number of people being diagnosed with liver cancer among people with hepatitis C, and we've at least prevented further increases. And I'll explain a bit later why I think it takes somewhat longer to get this turnaround for liver cancer. Hepatitis B, again with liver cancer, the trend had been fairly sort of steady up until the elimination period and has remained relatively the same, although we believe there's been an impact. Okay. I'm now sort of moving to show you what we call the age standardized incidence rates. And the reason why we adjust for age is that people with hepatitis B and hepatitis C in Australia are what we call an aging cohort. We have new people coming in, new cases of infection, new cases, for example, coming in from migration, particularly with hepatitis B. But the overall cohort of the population of people with hepatitis B and hepatitis C continues to age. So we would therefore expect an increasing burden as many people have been infected long enough to develop advanced liver disease complications such as liver failure and liver cancer. So we adjust the rates to what we call an age standardized incidence. That gives you a measure of what we would expect is the individual risk. So for someone with hepatitis B, what is the individual risk of developing liver failure? And you can see this steady decline from the early 2000s in the individual sort of risk or the age standardized incidence. We also see that in the case of hepatitis B, liver cancer. So that's good news. It happened from the early sort of 2000s. The introduction of initially entecavir, tenofovir, then entecavir in the sort of mid 2000s obviously helped continue that decline, both for liver failure and liver cancer. Then we wanted to look at whether the what we call the elimination era from 2015 onwards has in it of itself had an impact. So we did some analyses that predicted what the curve would have been for liver failure and liver cancer numbers, and then used 2015 as what we call an inflection point to see whether there'd been any change in that sort of trend. So here you've got the actual trend in terms of Hep B related liver failure events and what we would have expected without the elimination era compared to what we've observed. So we sort of force this inflection point for 2015, the start of the elimination era. And you can see some relatively modest improvements in reduction in liver failure events and also for liver cancer events compared to what we expected without the elimination era. Moving on to hepatitis C, the same process. So we're looking now at age standardized incidence. So this is individual risk of decompensated cirrhosis or liver failure. And pretty stable sort of up until the elimination era. So not much change at all, but then quite a marked reduction around about a halving of the individual risk of developing liver failure in people with hepatitis C. So really incredibly encouraging to see this downward trend since 2015. Not quite as marked with liver cancer, and that sort of parallels what I showed you before with the actual sort of numbers of events comparing liver failure to liver cancer, but still an encouraging sort of downturn in terms of the individual risk of developing liver cancer. Now moving to the similar analysis we did with hepatitis B, where we looked at the predicted numbers of liver failure and liver cancer versus the observed. And there's no doubt that the introduction of direct-acting antiviral therapy, and in fact, we had some introduction from late 2014 with compassionate access programs. There's no doubt that they came at exactly the right time. Without the introduction of DAs and without the elimination era, we predicted that there would be an increasing sort of quite marked increase in both episodes of liver failure and liver cancer, particularly with liver cancer. And you can see what we've been able to do in terms of the observed numbers versus the predicted numbers. Really quite impressive impact. Okay, so let's sort of look at liver-related deaths. Okay, so in terms of hepatitis B, liver-related deaths, there's sort of slight sort of increase through the two sort of decades, 2002 to 2022. That's a crude number of deaths, and this is the age standardized deaths. So just to remind you, we define a liver-related death by someone who's been admitted for liver failure or liver cancer and has subsequently died. Some of those deaths may not have been related to liver disease, but we expect that large, if not the vast majority of the deaths were. And you can see the age standardized liver-related mortality rate during the elimination era has continued this steady decline that had occurred from the early sort of 2000s. So again, sort of encouraging further decline, as you would expect with the reduction that we saw with liver failure and liver cancer. Moving on to hepatitis C, a similar sort of pattern, although a more marked sort of turnaround in terms of the crude deaths. And again, a slight sort of increase, if anything, in terms of the age standardized liver-related mortality. And that's been turned around since the elimination era in 2015. Just looking a bit more closely at the liver-related deaths among people with hepatitis C, this is the total mortality rate. This is the population level rate. So this is the number of deaths per 100,000 per year. And remember, I showed you in the early sort of slide, that sort of target of less than 2 per 100,000 population per year. So this is a total liver-related mortality incidence rate that peaked at about 4.5, so sort of well above the WHO sort of target of 2. It's come down to 3.5, dividing that in terms of those deaths following liver failure or decompensated cirrhosis and liver cancer. A more marked reduction in the liver failure related mortality, and they're pretty similar at the moment. And just putting that 2 per 100,000 population per year target. So we've got a lot more work to do. We need to sort of bring this down quite a bit more over the next sort of 7 years, 6 to 7 years, but I think we can achieve that with a some key sort of strategies. Just wanted to move on to survival following liver cancer. So initially, we're looking at survival following hepatitis C liver cancer. We all know that overall survival is pretty poor once you are diagnosed with liver cancer. If we go back to the early cohort, 2001, 2007, really quite sort of appalling survival of around about 9 or 10 months. We're looking at subsequent cohorts. We can see by 2015, so the start of the sort of elimination era or DEA sort of period, we've increased that median survival. So that's the time survival until half the people with the liver cancer diagnosis have died. So that's increasing from about 9 or 10 months up to almost 18 months. So almost a doubling in the survival from this earlier cohort period, 2001, 2007, up to the start of the elimination era, and pretty stable in that subsequent cohort. So that's good news, and we think that relates to possibly some earlier diagnosis of liver cancer, but also a marked reduction in the risk among people with liver cancer of developing liver failure. And many people who die from liver cancer actually die from developing progressive liver failure. And with hepatitis C cure, we're reducing that risk considerably. So moving from hepatitis C liver cancer survival to hepatitis B liver cancer survival, immediately you can see that the overall survival is much better. So I said before, in 2001 and 2007 with hepatitis C, the survival was only about 9 or 10 months. We can see here with hepatitis B, it's already beyond a year, but really quite impressive increase in survival going from this earlier cohort. Even prior to the elimination era, 2008, 2014, we'd increased survival to well over 2 years. And you can see that we haven't even reached the sort of median survival for this latter two sort of cohorts. So 2015, 2018, and 2019 to 2022 diagnoses. Clearly, the survival will be beyond 3 years. I think that's a combination of earlier diagnosis from high levels of screening of the at-risk population, maybe some cases of liver cancer we know that occur pre-cirrhosis in people with hepatitis B, so that thus improves survival compared to hep C, where almost all the liver cancer cases occur in people with cirrhosis. And also the increasing coverage of hepatitis B antiviral therapy and a reduction in risk of liver failure. Just wanted to sort of look at another issue of late diagnosis. So we've talked before in many sort of forums about how late hepatitis diagnosis is a missed opportunity. So we wanted to look at how we're sort of tracking in terms of late diagnosis among people with hepatitis C related decompensated cirrhosis or liver failure. And this is the total number of events, and these are those that have been diagnosed late. And by late, we mean they've had their hepatitis C diagnosis within 2 years of presenting with liver failure or liver cancer in the subsequent slide I'll show you. So that's a real sort of missed opportunity for effective interventions. So you can see back in the early 2000s, almost 35 to 40% of those presenting with liver failure had only been diagnosed either at the time of that presentation or within the 2 years prior to that. Encouragingly, that proportion has declined over time, and it's about 20%. We look at hepatitis C related liver cancer, again, a similar sort of trend, initially around about the sort of 40% mark, but down to around about the 20% mark. It's still too high, and we need to sort of get this down to below 10% over the coming sort of years. Contrast that with hepatitis B, and those proportions are somewhat high. You can see even over half of the cases in the early sort of 2000s had late hepatitis B diagnosis, and that's still around about 30%. So this is for liver failure. The next slide will show you the proportion for liver cancer. And then if we compare hepatitis B to hepatitis C in terms of late diagnosis, you can see here a consistent trend where the proportion of late diagnosis among people with hepatitis B presenting with liver failure and also with liver cancer is consistently higher than for hepatitis C, although both of them trending down nicely. But we need to get hepatitis B proportion down to, over the next sort of few years, more so, although we'd like to get both of them coming down. Okay, so in terms of further analyses that we're planning for 2014. I said we're awaiting the data from the MBS and PBS, so we'll be doing analyses of cascades of care, including uptake of testing for Hep B DNA and for B, and Hep C RNA for hepatitis C, and also treatment uptake, including key factors. We have a more sort of nuanced demographic sort of picture we will be able to provide, including the impact of housing and social status, and also key populations, so drug dependency populations, overlapping obviously with people who inject drugs, people who've been incarcerated, people from culturally and linguistically diverse backgrounds. We're also going to look more closely at this late diagnosis sort of picture. So, okay, we've got the proportion that are presented in terms of presenting with late diagnosis, but what are the key factors that predict that late diagnosis, and how is that late diagnosis among these key populations? We also want to look at late treatment. So it's one thing to be diagnosed late, but there are many people, even if they've diagnosed a decade and more ago, who still haven't had effective interventions, particularly antiviral therapy. So we're really keen to sort of look closely at that late treatment uptake. And obviously, in terms of the mortality that I've shown you liver-related deaths as defined, but we will have more information coming through on cause-specific mortality. So we'll be able to look at trends in liver, drug, and other related causes of death to see whether the elimination error has had an impact, not only on liver-related mortality trends, but possibly drug-related mortality. The other project I'd like to present is a project that Heather's leading, which is looking at women and children. And we're particularly interested in seeing what follow-up the children born to mothers with either hepatitis B or hepatitis C have had. So through linkage with perinatal data, the registry of births, deaths, and marriages, we'll be able to develop cohorts of sort of mothers and their children who have been diagnosed with hepatitis B and hepatitis C, then linked to the same sort of administrative data sets that I've been talking about, and look at a range of sort of outputs, including testing and interventions for the children. We've done some preliminary work just looking at the numbers that we'll have. So among over 77,000 women with either hepatitis B or hepatitis C notification in New South Wales over the 2-decade period, there's the breakdown of those with hepatitis C and hepatitis B, so very large sort of populations. And these are the numbers of children that have been born in New South Wales over that period to those mothers. And just a very preliminary look at how many of the children have been notified with hepatitis C. So of those, over 36,000 babies born to hepatitis C notified mothers, we have 1,868 children that have been diagnosed and notified with hepatitis C, 145 children from the hepatitis B positive notified mothers that have also been notified. So at the moment, that's 0.6% of the children born on the hepatitis B side, and just over 5% of the children born on the hepatitis C side have been diagnosed and notified with those conditions respectively. So a lot more work to do in this project, but it's pretty exciting to sort of to get a bit of a handle on what's been happening to children of women with hepatitis B or hepatitis C. And finally, just a further acknowledgement, I've acknowledged Heather and Shane, but Marianne did a lot of the sort of work over the last decade or so on the linkage, Richard and Amy on the sort of modelling work. And once again, thanks so much to New South Wales Health for the support.
Brilliant. Thanks so much, Greg. Lots for people to sink their teeth into later in discussion. We wanted to pick up on two particular elements for people from culturally and linguistically diverse backgrounds and people with experience of incarceration. So to keep things going, I'm going to hand over to Natalie for 10 minutes. Over to you, Natalie.
Thank you so much, Carla. Let me know if you can see my screen.
Not yet. It's coming. And yep, you're good to go.
Fantastic. Thank you so much. Thank you, Greg, for that fantastic presentation, really insightful. Today, I thought of discussing some considerations for our CALD communities without going too much in detail into the data, but for us to reflect how can we assess the data in the light of what are the needs for the changing fabric of our population. I would like to also acknowledge the traditional custodians of the land in which we all live and work. From my end, today I'm meeting from the land of the Gadigal people of the Great Eora Nation, and would like to extend my respects to elders past, present, and emerging, as well as Aboriginal colleagues joining with us today. So something for us to consider when analyzing the data, yes, of course, we look at all of the information sources that Greg referred to, but also we need to have in consideration what is the global and regional prevalence of both hepatitis B and hepatitis C, and to cross-reference that with immigration patterns and mobility and who is currently coming to Australia. The importance of doing that is because if we only look at our notification data and the data sets that are coming through our clinical services, we are reactive. But if we have a look at the global prevalence as well as the migration patterns and mobility, we have a better capacity to plan for our services and forecast what we will be seeing. And this is both for the prevention of viral hepatitis transmission, as well as early intervention and the prevention of liver discompensation and hepatocellular cancer. So if we look globally, viral hepatitis is still on the rise as one of the key reasons of mortality and mobility, and hepatitis B on top of hepatitis C. If we look at some of the migration patterns of the past decades, we have seen a shift from migration from Europe to migration to East Asia as well as continental Asia. And this has a huge implication in the prevalence of hepatitis B as well as hepatitis C. So when we have in consideration a prevalence in country of birth, it's very important we don't only think about the current prevalence of who is coming to Australia and what's the prevalence in the country of birth, but also that we reflect in historical prevalence. This is particularly important when we think about the development into cirrhosis and liver cancer. So as an example of this, we can reflect on the Chinese-speaking communities being some communities coming from high prevalence countries, which have done amazing work in reducing the current prevalence through vaccination programs, as well as a massive screening in the population. But we have community members who may have migrated to Australia decades ago and have missed out of those screening and vaccination programs in the country of birth and also in Australia. And this is the people who may be coming through our clinical services at the moment with advanced disease and are those late diagnoses. One consideration we also need to have is the increase in temporary visa schemes coming into Australia. So when we cross-reference our information, we have to ensure that we have a capacity in our system to measure what is happening with community members who are Medicare ineligible and maybe coming through our publicly funded services in different touch points, but having most of their care done in a private capacity through private insurance, GPs, and primary health settings. So some hepatitis B considerations, and as it was discussed by Greg, where we are really coming short is in the cascade of care, and in particularly for CALD communities, is not in the testing, but in the linkage to care. If we reflect on the communities that are affected the most in New South Wales, we have the Chinese-speaking communities, Vietnamese communities, Philippines, South Korea, and then going into Thailand, Italy, and Cambodia as the key countries. But if we look at the smaller numbers, we have also identified some emerging communities, in particularly the Mongolian community that is coming to Australia as international students and has the highest prevalence of hepatitis B and hepatitis C in the world. Another considerations for hepatitis B and the coverage of vaccination for our migrant populations is, again, who are the unvaccinated cohorts that could be living with chronic hepatitis B and silently evolving into cirrhosis, and liver cancer. So as I mentioned before, all of these populations that have missed out in the different programs, both in the country of birth as well as in Australia. If we think about that, it can be very young people already, people from Asian-born communities between their 20s and 30s, teenage years for African-born, and very importantly, to consider inconsistent vaccination coverage among new and emerging communities. So this has been very important feedback that we had from our colleagues, that many people and mothers coming through perinatal services, they will recall vaccination, but that vaccination was not effective. So these are some of the challenges for us to consider. And finally, some considerations for hepatitis C virus, apologies for that little typo there, is that the country of birth is not currently recorded systematically in the notifications, and CALD communities have not been considered a priority in the policy development for hepatitis C. However, we know that alternative modes of transmission is one of the drivers for hepatitis C among our CALD communities, and this includes mass vaccination programs in the past decades. This is very important, for example, for Middle Eastern communities, in particularly people that came from Egypt, ancestral and medical and dental procedures, as well as ancestral traditional practices as mode of transmission for past infection, as well as current infection for people traveling back to their country of birth, and perhaps, having a dental procedure because it's cheaper, or even, having some tattooing. And I have learned, for example, tattooing of eyebrows, and perhaps community members who won't see themselves in risk of acquiring hepatitis C. So this is all for me. I have tried to do a little bit of a overall showcase of our considerations for data linkage with viral hepatitis. Don't hesitate, please, to reach out if you would like more information or to discuss further.
Thank you, Natalie. That was really fantastic and did give a heap of context to understanding viral hepatitis among culturally and linguistically diverse communities. Just fantastic. And to note that MHAS are just a wealth of knowledge and information. So please do reach out to Natalie and colleagues if you need such expertise. So I'm going to hand over to Tracy Brown from the Justice Health and Forensic Mental Health Network. I remembered my F. Over to you, Tracy.
Thanks, Carla. Okay, can you see my screen?
Yes, all good to go.
Great. Okay, so firstly, I'd like to acknowledge the traditional owners of the land in which we all meet. For me, it's the Gadigal and the Bidjigal people down by the Cooks River, and pay my respects to elders past, present and emerging, and extend that respect to any Aboriginal people in the room with us today. I'm just going to go and give you a quick overview of what's happening around hepatitis and advanced liver disease in New South Wales prisons. And if time permits, a very quick case study just highlighting how sometimes people coming into custody can really address their healthcare needs and end up with better health outcomes when they leave. So firstly, we have 39 prisons in New South Wales, 3 of which are private. At the moment, there's approximately 12,500 prisoners currently in public system and about 3,000 in the privates. And this has decreased quite substantially. Pre-COVID, there was around 15,000 prisoners, and they were expecting that numbers would come back up, but thankfully they haven't. So that's a good news story. We have approximately 25 to 30,000 prisoners that cycle through the system annually. I think the average stay is around about 9 months. And on average, prisoners move around 4 times a year. So there's a huge amount of movement in and out of prisons and around the prison system. We have, unfortunately, a mass overrepresentation of Aboriginal people in custody, approximately 30% in the adults and 45% in juvenile. So really heaps of work needs to be done in that space to reduce those numbers. The priority populations that we work with in population health are people who use drugs, Aboriginal people and people living with bloodborne viruses. And we've managed to decrease the positivity rate for Hep C over the last few years since the introduction of DAAs. Originally, around 2016-17, we were looking at about 13 to 15%. we're now down to about 6 to 8%. So again, that's just due to mass testing that we've been conducting since then. So since the introduction of DAAs, we've initiated 6,914 people prisoners onto treatment, and that was as of January. And we're looking at doing around about 1,100 to 1,150 this year. We still have a KPI of 1,250 through the Ministry of Health, but we're pretty pleased that we're able to get to these high numbers. And we are leading the state in initiation numbers. The ministry has estimated that we've saved around $12 million in avoided health costs, and that was since September last year. We have quite a few different testing modalities. We have the Cepheid point of care machine, the dry blood spot, obviously venipuncture, and we've recently in the last few months introduced the 1-minute hepatitis antibody test, which has really enabled us to increase that mass testing. We've got different models of care. We have roaming and targeted testing. So sometimes we'll go into prisons and have a list of all the people that are at high risk of hepatitis C, and we'll just test them. Other times we roam around the state. We've got 2 nurses with 2 machines that roam around the state doing testing. And we'll just do mass testing for anyone that wants to come up on the day. We've got Cepheid machines in 6 different prisons as well. We conduct our high-intensity testing campaigns, sometimes with and sometimes without health promotion. We find with health promotion, we get a much higher uptake, and we targeted around about 95% uptake, is what we're going for when we do these high-intensity testing campaigns. Patients can self-refer, and we have an early detection program where anyone who identifies to be at risk is put on a wait list to have their bloods taken. And we conduct all of this testing in the health centres, in the yards, in the pods and in the wings. So when we're looking at our data, for this, our hepatitis C initiations, you can see in the table down the bottom, so, obviously started very low, but built up quite quickly, up to almost 1,500 in 18-19, and then decreasing slightly. And then again, because of COVID, in 21-22, massive decrease in the numbers initiated, and that was the year that COVID really hit the prison system. But moving back up now, and as I said, we're hoping to do about 1,150 this financial year. The big thing we're having issues with, or what we're seeing a lot of, is retreatments in the prison. Obviously, without a prison needle syringe program and limited access to harm reduction resources, this is something that's going to continue to happen. Numbers again started low, but increasing substantially. Last year we had 316 people that were retreated for prison, and this is not including their retreatments in community. This is only the treatments that they have when they're with us. And then we actually clinically review all of our retreatments, and they get reviewed by hepatology specialists. And out of all those that we've retreated, 1,167 reinfections we've confirmed have been, retreatments we've confirmed as being definite reinfections. 312 have occurred whilst a person is continually in custody between treatments. So we've got definite proof that 312 of those patients have been reinfected whilst in custody. The proportion of reinfections amongst Indigenous patients initiating treatment fluctuates around the 58% mark. And to date, 21 people have been confirmed as experiencing 2 reinfections during the 1 custodial stay. So, getting quite devastating when we're seeing people come in and getting reinfected, more than once in 1 stay. And again, the definite overrepresentation of Indigenous people in this data, which is again very distressing. You can see in the table, 2 treatments, 56%, 3, 66, 4 treatments, 75, and then going up to 76%. And we've now treated someone for a 6th time, and unfortunately that person is Indigenous as well. So just have a quick look at our hepatitis B testing and trends. So in January this year, we had 106 patients with hepatitis B throughout the prison. So that's out of that 12,500 people. and 23 of those patients are in private hospitals. And just because of all those movements in and out, those people go in and out of private, public all the time. So we're seeing those patients as well. All those patients can be seen by our weekly infectious disease clinic, and they get monitored. They all have an alert on them, and we run a quarterly report just to make sure that everyone with an alert is linked into care. We obviously have a vaccination program, and we've just received ethics approval to conduct a point prevalence hepatitis B study with the aim eventually to do targeted testing of those high prevalence countries that we're having in custody. Our pregnant women with hepatitis B are managed by the midwives and our hep care team jointly. And our hep B antibody positive patients are also tested for hep D. And currently we've got 16 patients that are co-infected with hep D and hep B. So we're trying to keep an eye on that at the moment just to see how that trends. With our advanced liver disease, we have fortnightly mortality and morbidity meetings with a hepatology specialist, Dr. Paul Haber, to discuss all of our patients of concern. Patients can be seen bi-weekly, but again by the infectious diseases clinic. We run the quarterly report again just to ensure everyone's being monitored. These patients are referred to integrated care, palliative care, and the cancer care team as part of a multidisciplinary team approach. And in January this year, we had 59 patients with advanced liver disease, and these numbers are gradually decreasing, and we believe that's due to early detection of hepatitis. We're doing so much mass testing and getting people started on medications quite quickly. And that number in March, so just in a couple of months, decreased to 39. 20 of those patients have achieved SVR while in custody, and 3 are also on hep B treatment. And obviously many other risk factors, as everyone would find: fatty liver, substance use disorder, and 75% actually report that alcohol is use is one of their main factors. And we connect patients to care on release. We've just started a new, we do have referral pathways with all of the LHDs, but we've just started a new position with CESPN, the Central Eastern Sydney Primary Health Network, to link patients in care on release to GPs. So we're just starting that program now. So it'll be interesting to see how that goes, and if our patients are happy enough to go along to GPs and find it acceptable. I just thought I'd quickly run through a case study, and this just highlights that sometimes people accessing healthcare in custody can be very beneficial to them. So we have this man here. He's a 53-year-old Aboriginal man. He's had a lengthy history of substance use, and he commenced as a teenager, so been using for a long, long time. Treated for hepatitis C in the community in 2006, and he did achieve SVR. He's been in custody since January 2017. Unfortunately, he refused all blood pathology until August 2020 due to poor venous access, so he wasn't interested in anyone testing him. Then he was diagnosed. We did manage to test him, thankfully, in August 2020, and he was diagnosed with hep B and unfortunately cirrhosis. In September, so the following month, we sent him off for ultrasound and had incidental findings of lesions in his right kidney and evidence of fatty infiltration and no confirmation of cirrhosis. So originally that was confirmed on FibroScan, but then the ultrasounds did not confirm that diagnosis. In November 2020, he had a CAT scan confirmed, and they confirmed 2 lesions in his right kidney. He was commenced on entecavir for his hep B in December 2020, and then he was admitted to hospital in John Hunter and had a nephrectomy in April 2021. The same year in August, he had hemangioma confirmed in liver and a presence of hepatic steatosis. In the same month, he disclosed extensive substance use history, requested support to address his behaviours, and so we organised an urgent referral to drug and alcohol for assessment. He reported that the care that he received to date was superior to anything in the community, and he felt he had been given a second chance to improve his health and future choices. And we tend to see this a lot amongst our Aboriginal people. A lot of them are saying that they don't access care in the community, and whether that's because, you know, they're living in small rural towns or they don't have access to care, but they just seem to, when they come into community, they seem to be more inclined to get their health needs met. He commenced Buvadil in 2021 and remains stable on this program, which is fantastic. He improved his dietary choices within custody with pop health education. So our nurse practitioner met with him regularly and went through healthy eating for his liver so he could improve it. He reduced his weight by 15 kilos. And in January 2024, there was no evidence of cirrhosis or metastases on his CT scan. His hemangiomas in liver remain stable. Unfortunately, he remains in custody until 2027, but he has become a peer in his pod on liver health and lifestyle choices. So he's really taken on board all of the education and the fact that he really wants to improve his healthcare while he's here. So that's it from me, but I just wanted to acknowledge people that contributed to this presentation as well. Tracy Jones, our hepatology nurse practitioner, Tom Wright, the acting programs manager, and Christine Sotomayor, who's our surveillance officer. So thank you very much.
Brilliant. Thank you, Tracy. And I think your dog had a few things that it needed to say during that presentation as well. So, you know,
I'm
good
sorry
that it's a, you know, whole of family event today. There's a question for you in the chat, Tracy, but I'm going to just pick up on something, Greg, you said right at the beginning about the change in targets, a shift from the relative reduction original statement to a crude population estimate. And you may have explained it, but I might have missed it, about why that's an important change.
Yeah, there are a couple of reasons why I think it's an important change. In fact, I've been advocating to WHO for several years to make the change, is that having the relative reduction very much depends on where you were in your curve in 2015. So Australia was increasing in terms of the number of hepatitis C related deaths, and it was inevitable without treatment that we would have doubled, trebled the number of hep C related deaths in the coming sort of years and decades. Whereas a country like Japan, much older cohort of people with hepatitis C, even the United States, 15 years median age older, they were sort of getting to the peak. So even without the introduction of DAs, they would have had a turnaround, whereas it's sort of unfair to the countries that were on that sort of escalating path. So if we had compared the predicted sort of number of deaths in 2030 to the actual, we'd easily get more than 65% reduction. But we were stuck with 2015 as a baseline when we would have had this sort of increasing number. So it's sort of a very unfair sort of, I think, target. So I think that the total population sort of revised targets make sense. It also means that you can improve your surveillance system. So a lot of low middle income countries have relatively poorer surveillance systems for liver-related deaths. So you don't have to compare to 2015, you just have to improve your surveillance system, improve your data, then you can monitor that sort of liver-related death sort of rate from now on to 2030. So I think it's a pragmatic move and it makes sense.
Great, thank you for that clarification. Tracy, over to you from John from Hepatitis Australia about the astounding estimate of the $12 million cost saving in avoided healthcare costs. Does this incorporate reinfection and retreatment, and is it available publicly for people to cite? John, is there anything else you want to add? I saw you turned your video on.
Only if my question's not clear. I've kind of struggled with how to word it, but
no, it's clear, John.
Yeah,
so
beautiful.
the Ministry of Health obviously received the data, well, from the PBS about anyone who's been commenced on treatment from us. It's our pharmacy data that we send in. So it's all data that they collect, and they produce a quarterly hepatitis C report card. I do believe it's available on their website. It's not a secret. It's sent out everywhere, and they estimate what every LHD has saved in averted healthcare costs in that report. That's answer your question. And it basically, so I don't think they don't split it between how many are reinfections or retreatments. It's just the number of treatments that are given out.
Okay. So if I can, Carla, I guess I was starting with the premise that treatment and cure saves healthcare costs, but an absence of prevention and therefore reinfection and retreatment adds to healthcare costs. And I was wondering whether both, the bottom line incorporated both figures, and in fact whether the second was included at all.
I do know that I did see Annabelle from the Ministry of Health, who produces that report, was online. I don't know if she could add anything in the chat or.
Hi Tracy, hi everyone. I need it. It's an older formula, and so we are looking to update it. It initially was just looking at what healthcare costs were saved by treatment alone. It didn't incorporate other prevention methods, and it was first developed, when reinfection rates were a lot lower because, we hadn't treated as many people. So we are looking at updating the formula so it is a bit more accurate. And in theory, it would be fantastic as well if we can incorporate some of those other factors as well. So leave that with me. I think it's a really important formula, one that we actually do get questioned on quite a lot, and I think is quite useful for a lot of the work we do. So it would be good if we can strengthen it and update it a little bit further. It's quite simple in the end, so I think there's more we can do with it.
Great.
Thank you.
I'm going to come to you in a moment, Greg. There's two questions in the chat from Mia and for Libby for you. But Natalie, I wanted to pick up on something you said, that country of birth isn't currently recorded in Hep C notifications. Greg can pick up country of birth via data linkage. Do we need country of birth in notifications, or is it taken care of in the data linkage? What would it give us? What might it cost us to have that in the notifications data?
I think it will give us the opportunity to develop programs and strategies that we are not currently looking into. So definitely we do need that. At the moment, the investment in example out of point of care testing for CALD communities and exploring the opportunity of doing community-based testing is not a strategy we have explored in New South Wales, and that could give us the opportunity to uncover a new cohort of patients who have not been treated yet and could benefit from treatment. And it's I think it will be discussing about the cost effectiveness of early intervention and treatment. We will definitely prevent many of those late diagnoses, but also it's about equity to access to healthcare. So, at the moment, I'm working with my team in developing an up-to-date resource about hepatitis C, and there is no clear testing and referral pathways for the general community, and you are very much dependent on your general practitioner and who they refer you to. There is no clear pathway to publicly funded liver clinics. There is not this understanding of testing and treatment on the spot, and acknowledging that this has been an extremely successful strategy for other population groups of high prevalence, as in Justice Health, as well as NSP settings. It will be really good for us to understand which untouched populations we have not worked with, and having an understanding of country of birth or language spoken at home will give us that tool. Definitely. And also, again, I kind of start breaking down a little bit if there is difference between early diagnosis versus late diagnosis in hepatitis C. We don't know that in depth, as we, in example, we do know with other health conditions as HIV. And in HIV, in example, we have been able to very closely monitor the diversions in the curves by actually having that piece of information. So, yeah. So as a short answer, yes, Carla, it will be very beneficial for us to invest in that exploration. I think it's going to, open for us a range of possibilities. And again, to look at the population groups who have been living in Australia for a long time, may have been exposed long ago, and are silently evolving into cirrhosis and liver cancer, as well as having a better understanding of how mobility is impacting new diagnosis and the interactions between perinatal health, as well as injecting drug use. There are so many nuances we know so little about hepatitis C and health communities. There is a lot of work we could be doing.
Brilliant. Thanks for that context, Natalie. Greg, there's a couple of questions in the chat for you about quality of life, other causes of liver-related mortality, and then the figures for perinatal transmission that you presented at the end. Do you want to jump into those, please?
Yeah, so I might just quickly address the country of birth issue as well. So I think it's going to be very difficult to have countries of birth on notifications because there's a large number and the vast majority are through laboratories. But we need better linkage mechanisms. We've got country of birth in our linkage, but the new initiative coming out of ABS called PLEADER is not only going to have country of birth, it'll have ethnicity because it links to census data. We'll also get data on emigration as well as immigration, so that's really important. So I think going forward, we'll have a much sort of more nuanced sort of characterization of cascade of care and other elements by both country of birth and ethnicity. Getting to the question, so one question about the numbers of perinatal transmission, 0.6 Hep B and 5.1 for Hep C. The low numbers of Hep B because of vaccination of mothers and babies, including birth dose and antibodies. I assume the numbers of Hep C transmissions are based on PRC results and not PCR results and not antibody testing. So firstly, their preliminary results, they're just notifications of children born to those mothers. So we can't say for sure that there've been perinatal infections. For example, on the Hep C side, it may be that we're looking at the age distribution. You might have, for example, someone gets diagnosed, notified in the late teens. That could have been a perinatal transmission. It could have been through, for example, risk behavior. So we'll be looking more closely at that. I think the low rate of diagnosis of Hep B amongst children born to women with Hep B could be some under testing, and that's what we really want to look at. What are the testing sort of levels? So that would be concerning, but I think it does reflect both infant universal vaccination, so for birth dose vaccination, and for mothers who have chronic Hep B, also immunoglobulin, and more recently, antiviral therapy for those mothers that have a higher viral load. So there should be very, very few perinatal transmissions for Hep B occurring in Australia. But I think we're still seeing it with hepatitis C. Just very briefly, there's hopefully some preliminary data that will come through looking at treating women with hepatitis C with antiviral therapy in the third trimester that we do now with hepatitis B. So in future, I think for women that still have active infection who are pregnant, we'll probably be treating them in the third trimester, so to cure the mums and prevent any transmission to their babies. Hopefully that's answered that one.
Other causes of liver-related mortality?
Yeah, so look, it's really interesting. We did some didn't have time to show the data, but we did some stratified analyses by people with a history of alcohol use disorder, which is the one you sort of think of in terms of comorbidities. I mean, along with fatty liver disease, but it was really incredibly encouraging to see, despite there being a much higher rate of liver failure, liver cancer, and liver-related death in those that reported a history of alcohol use disorder, since the arrival of DAs, there's been a really dramatic reduction in liver-related deaths among people with that combined Hep C and alcohol use disorder. So I think that means two things. One, by curing hepatitis C, we're reducing the sort of toxicity to the liver that two things could cause. But hopefully it also means that maybe going through the Hep C treatment process leads to behavior change in terms of alcohol intake. So we want to look at that sort of more closely. So that's a sort of glass half full view of that, is that you get a combined effect of Hep C cure plus maybe alteration, modification of alcohol intake in those with cirrhosis. So that would be a really good news story if that were the case.
And quality of life?
So we haven't got good measures through the linkage in terms of quality of life. We are going to look, because I said we're linking to social welfare and other sort of administrative data sets, we will be looking at a crude measure of quality of life in terms of disability support pensions and other social welfare, whether the DA era has had any impact in terms of trends in that. And we know that social and other factors and even availability and assessment factors influence take up of disability support pensions. So, but we think we should look at that closely. Unfortunately, we don't have good sort of specific quality of life data to sort of look at the moment.
Great, and we're just on time. Thanks very much also to Maria McMahon for dropping in that link to the health economics information. Lovely to have such a helpful, supportive community of people to work with. Thanks again to Greg, Natalie, and Tracy. You'll receive the recording of this in a week or so you can have a look at the presentation again for a refresher. Thanks to our presenters, thanks everyone, and thanks to the Ministry of Health for support of the BRISE program. Have a good afternoon.